Hello, this is Chris Ferrigno. In this discussion, we'll be introducing the 12 cranial nerves. So the first thing we need to discuss is exactly what is a cranial nerve. Well, think back to the extremities and we had all these peripheral nerves that we learned about, the ulnar nerve, the median nerve, the femoral nerve, obturator nerve, etc. Here in the cranium, we have peripheral nerves as well, and there's 12 of them. And these 12 nerves are essentially peripheral nerves that come from or go into the cranial vault. So they're all part of the peripheral nervous system, except for one, that would be cranial nerve 2, which has central nervous system tissue. They all emerge or either going into or coming out of the cranial cavity, which is why they're called cranial nerves. And they have sensory and or motor components. Some are sensory, some are motor, and some are both. As we can see from this image, most of the cranial nerves come from the brain stem region, with the exception of the cranial nerve 2, which goes around the midbrain, and cranial nerve 1, which is hardly shown right up here, and that's really associated with the forebrain or telencephalon. So once again, cranial nerves can be motor, sensory, or both. So they might have the ability to carry general somatic afferent fibers, bringing in sensory information from the environment, such as touch, pain, temperature, and other sensory receptor information. They have the ability to carry motor information out to muscles, skeletal muscles. They have the ability to bring visceral afferent information in. We all remember how the vagus nerve brings in information from the viscera, and that information is coming in through the vagus nerve into the brain. And 4 of the 12 cranial nerves have the ability to carry out visceral efferent information to structures such as smooth muscle and the cardiac muscle. Something other peripheral nerves cannot do, but some of the cranial nerves can do, is carry special sensory afferent information, carrying information such as smell, taste, vision, hearing, and balance into the central nervous system. Several of these nerves are derived from the branchial arches or from the pharyngeal arches, which we'll discuss next. The pharyngeal or branchial arches are paired structures associated with the pharynx that contribute greatly to the formation of the face, jaw, ear, and neck. Each of these arches consists of a mesoderm-derived core of mesenchyme that forms muscles of the head and neck, along with neural crest cells that contribute to skeletal elements of the face. So each pharyngeal or branchial arch has its own cranial nerve that innervates the muscles associated with that arch. So here we have the 4 nerves that are associated with the 4 branchial arches. Please note that arch number 4, which is associated with cranial nerve 10, the nerve you're currently most familiar with, the vagus nerve, actually is derived from arches 4 through 6. However, those 3 arches end up combining into the one single 4th arch. Here we can see the names and the numbers of the 12 cranial nerves. On the left is one of many mnemonics out there to help try to remember the names of the nerves. On the other side is one mnemonic of many that help you try to remember the function. And this is the basic function. So essentially it's telling you whether it's a sensory nerve, it's a motor nerve, or it's both a sensory and motor nerve. Generally, the cranial nerves are associated with the brainstem. Here we can see cranial nerves 3 and 4 associated with the midbrain, 5, 6, 7, 8 associated with the pons, and 9, 10, 11, and 12 associated with the medulla. However, we also can see that cranial nerve 2 is associated with the diencephalon, and cranial nerve 1 associated with the telencephalon. And here we can see cranial nerves 3 through 12 and how they relate or are associated with these various parts of the brainstem. Here we can see cranial nerve 3 coming out from between the midbrain and the pons. However, its nucleus is going to be in the midbrain. Similarly, cranial nerve 4 coming out from behind the brainstem, or I should say in the posterior aspect of the brainstem, with its nucleus in the midbrain. Cranial nerves 5, 6, 7, and 8, all associated with the pons, with 6, 7, and 8 coming out from between the pons and the medulla. This is called the pontomedullary junction. And then cranial nerves 9, 10, 11 coming out from the lateral medulla, and 12 located slightly more medial. Here we're looking in the cranial vault, or the cranial cavity. Here we can see the anterior cranial fossa, which houses the frontal lobe, the middle cranial fossa, which houses the temporal lobes, and the posterior cranial fossa, which houses the cerebellum, and lower down houses the brainstem. Since the cranial nerves are essentially peripheral nerves, they have to exit or enter the cranial vault to get to or from the structures they innervate. Here we can see those exit/entrance points of the cranial nerves. The image on the right is a nice overview of all the foramina in the skull that allows this transmission of the nerves. Once again, I've included the area of this petrous portion, or the petrosal portion of the temporal bone, as a guide to clue you into cranial nerves 1 through 6 is anterior to that, and cranial nerves 7 through 12 are posterior to that bone, or portion of bone. So here we can see the ethmoid bone. This is the cribriform plate of the ethmoid bone, allowing for the transmission of cranial nerve 1. The optic canal, allowing for cranial nerve 2, the superior orbital fissure, which you would need to turn the skull a little bit to be able to see up underneath this cleft here, allowing the transmission of the nerves going into the eye. So in other words, cranial nerve 3, 4, and 6, and then V1, which is going to be the ophthalmic division of cranial nerve 5. Then we have the foramen rotundum and the foramen ovale for the second and third divisions of trigeminal nerve. Around, or just posterior to the foramen ovale, is the foramen spinosum in this region, allowing for the transmission of the middle meningeal artery. Just medial to the ovale and spinosum is the foramen lacerium, which doesn't as much allow for the transmission of nerves. However, it's filled with cartilage in a live human, and obviously that cartilage dissipates in the skull, so we have a foramen. And so that's cranial nerves 1 through 6, and then we have the petrosal portion of the temporal bone. Just behind that is the internal acoustic meatus, allowing for cranial nerve 7 and 8, and then the jugular foramen, allowing for the transmission of the internal jugular vein, plus 9, 10, and 11. And then right before the foramen magnum, which we can see here, just superior to it, you would have the hypoglossal canal for cranial nerve 12. For a much better description, please check out this video by James Pickering from Leeds University, who does a nice job in describing these. So here we see the first cranial nerve, the olfactory nerve. Again, it's associated with the telencephalon and essentially the forebrain. So it's going to come out of the brain tissue, extend forward. Remember, we're looking at the base of the brain. So if we were to take this brain, flip it over, and turn it up inside of the cranial cavity or cranial vault, this would be the left olfactory bulb, as is this one right here. So this olfactory bulb is going to extend forward, and it's then going to rest on the cribriform plate of the ethmoid bone, seen right here. You see the green area, and that has some little apertures in there, or some openings, to allow for the transmission of the actual olfactory nerve fibers. So this balloon piece of tissue is the olfactory bulb extending back off of this would be the olfactory tract. Here we can see that, which then goes into brain tissue. And here we can see that olfactory tract expanding into the olfactory bulb, sending down the olfactory nerve fibers through the apertures in the cribriform plate of the ethmoid bone. Recall that the olfactory nerve is composed of special sensory afferent axons from receptors in the olfactory epithelium at the top of the nasal cavity. These are bundles of axons that pass superiorly through these perforations and ultimately go through the olfactory bulb into the forebrain. Cranial nerve 2 is the optic nerve. Here we can see on the base of the skull the optic chiasm right here in the middle, extending out anteriorly or forward from that chiasm is the optic nerve. Extending back from the chiasm would then be called the optic tract. So here we can see the optic chiasm with the optic nerve extending forward, and then the optic tract is beginning to extend backwards. The optic nerve is sensory only, and therefore all the signals will be going from the back of the retina, extending back through this optic nerve into the optic chiasm, and then proceeding on to the optic tract. You can think of the optic nerve like a great big data cable. There's lots of information when we see things, basically information of light that's being transmitted back, ultimately back here to the occipital lobe. To get out of the orbit, the optic nerve has to progress through this region of bone called the optic canal. Here we can see the optic canal just medial to this other large opening called the superior orbital fissure. If you have a superior orbital fissure, you need to have an inferior orbital fissure, seen here. When you take an ophthalmoscope and you look into the eye, you see the retina. And here is the optic disc, which is the attachment of the optic nerve onto the retina, which is quite interesting because basically what you're looking at this point is central nervous system tissue just by looking into the eye. Here's that retina, and the retina is lined with photoreceptors. Information from those photoreceptors are being transmitted back through that optic nerve via the optic canal, and then back onto other areas that you'll learn very soon, ultimately being brought into the occipital lobe. Cranial nerve 3 is the oculomotor nerve. As you might be able to guess from the name, it's going to have something to do with moving or the motor control of the eye. Here we can see the oculomotor nerve coming out from between the midbrain and the pons, and that nerve is going to project forward through the superior orbital fissure, which is hard to appreciate there. Prior to going through the superior orbital fissure, it's going to go through this area called the cavernous sinus, which we'll talk about in a little bit, to eventually leave the cranial cavity via that superior orbital fissure. So here we see that superior orbital fissure just lateral to the optic canal, which is transmitting the optic nerve, as well as the ophthalmic artery. So that's that optic nerve and ophthalmic artery, which are transmitted through the optic canal. Through the superior orbital fissure, we'll see cranial nerve 3, cranial nerve 4, cranial nerve 5, at least the first division of cranial nerve 5, and cranial nerve 6. So 3, 4, V1, or 5, ophthalmic division, and 6. The eye has 6 extraocular eye muscles. The oculomotor nerve is going to innervate 4 of those 6 extraocular eye muscles. If here we see the medial side, that's the nasal bone right there, and this would be the lateral side. The oculomotor nerve innervates the superior rectus muscle, seen here, the medial rectus, and the inferior rectus muscle. It also innervates, the 4th muscle is this muscle that comes around obliquely underneath the eye, so that's called the inferior oblique muscle, which originates here from the medial side, but reaches around laterally, but also slightly posterior. So it's going to be responsible for rolling the eye a little bit. We'll talk about more about that in a second. The oculomotor nerve is also responsible for changing the size of the pupil. So it allows the pupil to get a little smaller. And we use that in case we want to let less light in to the back of the retina. And it also accommodates the lens in this area. So if we want to read something very close, our lens accommodates, and so the oculomotor nerve is involved with that. This slide summarizes what I just said. We see the 4 extraocular eye muscles, the superior, medial, and inferior recti, and then the inferior oblique muscle. Here, I forgot to mention that it innervates what's called the levator palpebrae superioris muscle. That is this muscle right up here. This levator palpebrae muscle helps to lift the eyelid. Here we can see through general visceral efferent fibers, the parasympathetic activity of cranial nerve 3 helps to constrict the pupil and accommodate the lens. Realize the movement of the eye and general function of the eye is extremely complicated. So what I'm about to show you is a generalization of sorts. The recti muscle are generally going to pull in the direction of their fibers. So here we see the superior rectus. It's going to give an upward pull, so it's going to bring the eye up. The medial rectus will generally bring the eye in. The inferior rectus will generally bring the eye down. The inferior oblique muscle, also innervated by cranial nerve 3, will spin the eye this way. That means the top of the eye will go that way. And that's called extorsion because we define the movement by where the top of the eye goes. So here we see this 12 o'clock position is going to go outward as this inferior oblique muscle pulls the eye this way. So once again, in addition to controlling those extraocular eye muscles, cranial nerve 3 has parasympathetic control of the eye, more specifically of the globe of the eye. And it serves 2 parasympathetic roles. First, let's say you're looking out ahead of you and you want to look at the book you're holding in your hand. You need to accommodate your lens. That's the first parasympathetic role of cranial nerve number 3. To do this, you need to make your lens more globular, therefore changing the focal length of the light coming in onto your retina. Also, let's say you're in a dimly lit room inside your house. Your eye, or your pupil specifically, needs to be wide open so that as much light as possible can get in so you can see the things in front of you. Then you open your front door and you decide to walk outside at high noon. Your pupil needs to constrict down, otherwise you're going to disrupt the photoreceptors in your retina. So your pupil needs to constrict. This is the second parasympathetic function of cranial nerve 3. Cranial nerve 4 is called the trochlear nerve. It's called the trochlear nerve because it innervates this muscle called the superior oblique muscle, which takes a wild course along the medial wall of the orbit. It goes through this trochlea, another word for pulley, and then it progresses posterior and lateral to attach onto the posterior lateral side of the orbit. The trochlear nerve leaves the brainstem and travels anterior through the lateral wall of the cavernous sinus and eventually leads into the cranial cavity via the superior orbital fissure. The function of the superior oblique is a bit complex, somewhat the opposite of the inferior oblique. If the superior oblique contracts, it's going to pull down this way, and this part of the muscle will pull that way. So looking down on this picture here, this muscle is the superior oblique. It's going to take this 12 o'clock position and roll it this way or in toward the eye. Remember, the inferior oblique is going to extort the eye. The superior oblique is intorting the eye. Another important function of the superior oblique is to draw the eye down and out. Now, how can that be? Again, here we have a superior view and I've highlighted the line of pull of the superior oblique. Realize that the superior oblique muscle reaches very far laterally and posterior on the superior surface of the eye. Therefore, when it pulls the superior lateral posterior eye forward, medially, and anteriorly. Therefore, the anterior eye, or the pupil of the eye, is going to deviate downward and laterally as a result of this line of pull. So not only does it do intorsion of the eye, but it also can bring the eye down and out. Again, this is when the eye is positioned in forward gaze, so the eyes are pointed straight ahead. The trochlear nerve takes quite a unique route to get to the orbit. Here we can see in the lower midbrain the trochlear nucleus. On the right side, the trochlear nucleus sends off essentially the left trochlear nerve. It's going to come out the back of the midbrain, which is unique for the cranial nerves. It's going to then loop around contralaterally and ultimately innervate the superior oblique muscle. Let's say that the trochlear nerve was lesion, and it is somewhat common to get a trochlear nerve injury because of that pathway it takes, that looping pathway it takes from posterior all the way through anterior around the brainstem. So we have an eye that's positioned looking straight ahead. There is some tethering of the eye, pulling it this way by the superior oblique. Let's say the trochlear nerve is out, thus there is no pulling, tonic control of the eye, pulling it this way, so that the other muscles that are innervated by cranial nerve 3 are going to be pulling up and over, and therefore the eye will be resting in forward gaze a little up and in because of this lack of down and out pulling of the eye. So far we've seen two cranial nerves that we've discussed that go through the cavernous sinuses. You may be asking at this point, what are the cavernous sinuses? Well, here we can see them in blue. They sit on either side of the sella turcica, which is another name for the Turkish saddle. Here's the pituitary gland. Here's the optic chiasm. Just under here would be a segment of bone called the sella turcica. On the lateral margins of the sella turcica is a network of veins, if you will. This is the dural venous sinuses that help to drain the venous return of blood of the brain. You might note here that the eye has an ophthalmic vein that drains the eye posteriorly into the cavernous sinuses. Feeding from the back into the dural venous sinuses is the blood from the brain to drain out the jugular foramen. Therefore, the cavernous sinus and the primary portions of the dural venous sinuses communicate via these two petrosal sinuses, the superior and inferior petrosal sinus. The superior one traveling along the petrosal portion of the temporal bone that I mentioned recently. Projecting forward from the brain tissue or from the brain stem would be cranial nerves 3 and 4, and in addition cranial nerve 6 and V1 that pass through this network of dural venous flow. Specifically, cranial nerve 3, 4, 6, and the first and second parts of the trigeminal nerve all pass through the cavernous sinuses. Now this is slightly different than the superior orbital fissure that we talked about before. Remember that the superior orbital fissure has 3, 4, V1, and 6. The cavernous sinus has 3, 4, V1, and 2, and 6. That means that if there ultimately is an infection in this area, that these cranial nerves could be affected. A common mechanism for an infection in the cavernous sinus is an introduction of a pathogen into the orbit, where, let's say, a bacteria develops an infection in this region, sends its infection down through the ophthalmic vein into the cavernous sinus. Now we have an issue in the cavernous sinus. Perhaps we develop a thrombosis within the cavernous sinus, and the infection essentially can press on any or all of these cranial nerves as they pass through the cavernous sinus, thus producing an impingement on that nerve and symptoms associated with that nerve. Cranial nerve 5 is the trigeminal nerve. It's a very, very large nerve. It has 3 divisions, V1, V2, and V3, or the ophthalmic division, the maxillary division, and the mandibular division. Here we can see the ophthalmic division going through the superior orbital fissure right after it has passed through the cavernous sinus. It's entered into the orbit. It's split into a few other nerves, including the supraorbital nerve that goes through the supraorbital foramen, the infraorbital nerve going through the infraorbital foramen, and other branches that ultimately serve the nasal cavity. We have the maxillary division, which enters the face through the foramen rotundum and ultimately serves the maxilla itself. And then we have the mandibular division, a quite large division that's going to come out through the foramen ovale and serve several areas, including the maxilla and the muscles of mastication and other muscles associated with the pharyngeal arch number 1. Two primary roles for the trigeminal nerve is to bring sensory information from all of the face and much of the head, and to also bring motor information to the muscles of mastication, or the chewing muscles, and this includes a few muscles in and around the maxilla. That's brought by V3. You can see the sensory information is brought by both V1, V2, and V3. Included in the sensory information is sensory of the anterior 2/3 of the tongue. We'll see in a few slides that the taste of the anterior 2/3 of the tongue is different. That's brought by cranial nerve 7. Because of all that sensory information from the face, from the head, and from the tongue, note that we have a large bulging of tissue here called the trigeminal or semilunar ganglion. That's this yellow area here. Recall that I said that cranial nerves are simply peripheral nerves, and recall in the periphery on the appendicular skeleton, when we had sensory information coming in through the dorsal root, there was a ganglia called the dorsal root ganglia. Well, this is essentially the dorsal root ganglia for the trigeminal nerve, where all the cell bodies of all these sensory axons are located. Included in the sensory distribution of V2 and the maxilla and V1 of the mandible are the teeth. So realize that within dentistry, if you were to have an injection of Novocaine or other anesthetic into this area, they're anesthetizing these nerves so that we don't feel the procedures being done by the dentist. Cranial nerve 6 is the abducens nerve. Here we can see the nerve coming out from between the pons and the medulla, close to midline. Distally, it goes out the superior orbital fissure after it's crossed through the cavernous sinus to insert on one muscle, the lateral rectus muscle. And imagine it's called the abducens nerve because this nerve is responsible for the abduction of the eye, because this lateral rectus will have an outward pull. Therefore, if you have a lesion of the abducens nerve in forward gaze, where the eyeball should be facing straight ahead, the eyeball would deviate medially because of the inward pull, mostly from the oculomotor nerve and the medial rectus muscle. Cranial nerve 7 is the facial nerve. Here we can see the facial nerve sharing with the vestibular-cochlear nerve, or cranial nerve 8, a common entrance/exit point for the cranial vault. It's through the internal acoustic meatus going into the petrosal portion of the temporal bone, but on the posterior side. The facial nerve is complex with a circuitous route in the skull and multiple functions. Here we'll just summarize these functions. I recommend watching the summary discussion on the facial nerve. So as you can see, the facial nerve carries taste from the anterior 2/3 of the tongue. It also has general sensation over just parts of the ear and behind the ear, not too important. It supplies a small muscle called the stapedius muscle, which attaches to the stapes, which helps dampen loud sounds, and to other muscles in the neck. Its primary somatic motor role is to carry motor information to the muscles of facial expression. These muscles are derived from the second branchial arch. It also provides parasympathetic signals motor to the lacrimal gland and the submandibular and sublingual glands. Note, it courses through the parotid gland, which we'll see in a minute, but it does not innervate that gland. That job is for cranial nerve number 9, or the glossopharyngeal nerve. Here we see the facial nerve. It's come out of the brainstem from the inferior pons, where it meets the medulla, and it's progressed through the internal acoustic meatus, through the middle ear, and ultimately has exited out through the stylomastoid foramen, in between the styloid process and the mastoid process, kind of in this area behind the ear. It's progressing through the parotid gland, but again, not innervating the parotid gland. And then it branches into 5 branches called the temporal branch, the zygomatic, the buccal, the mandibular, and cervical branches. A good mnemonic for this is the zebra bit my cheek from top to bottom. As you can imagine, the temporal branches will go upward into this temporal region. It does not, however, innervate the temporalis muscle, because that's a muscle of mastication innervated by the trigeminal nerve. But it does go upward. The zygomatic branches go upward but forward, so it generally innervates muscles just inferior to the zygomatic arch. The buccal branches go towards the angle of the mouth. The mandibular branches go towards the mandible, or towards the chin, if you will. And then the cervical branches go beneath the mandible. Cranial nerve 8 is the vestibulocochlear nerve. Vestibulo meaning balance and cochlear meaning auditory or hearing. Because it's special sensory, the cranial nerve 8 is carrying special sensory information from the cochlear apparatus through the internal acoustic meatus into the pons at the junction of the medulla. Once again, the vestibulocochlear nerve and the facial nerve both course together through the internal acoustic meatus. Cranial nerve 9 is the glossopharyngeal nerve. It exits and enters the skull through the jugular foramen, as does the vagus nerve, or cranial nerve 10, and the spinal accessory nerve, or just accessory nerve, cranial nerve 11. The glossopharyngeal nerve carries taste, or special sensory, from the posterior 1/3 of the tongue. So in summary with the tongue, the anterior 2/3 for taste is carried by the facial nerve. Sensation in the anterior 2/3 of the tongue is carried by the trigeminal nerve. General sensation of the posterior 1/3 of the tongue is also by the glossopharyngeal nerve. So the whole posterior 1/3 is carried by the glossopharyngeal nerve for taste and general sensation. There are visceral sensory fibers from the carotid body and carotid sinus, obviously very important for monitoring our blood pressure and our pulse oximetry. The glossopharyngeal nerve came from the 3rd branchial arch, and therefore it carries motor supply to one muscle derived from that 3rd branchial arch, the stylopharyngeus muscle. It can be helpful in identifying the stylopharyngeus muscle in the neck by looking for the glossopharyngeal nerve coursing directly over top of the muscle when looking on a posterior view. The glossopharyngeal nerve is one of the 4 parasympathetic nerves. in the head. Acting through the otic ganglia, it stimulates the parotid gland to secrete saliva. Recall the other salivary glands, the submandibular and sublingual gland, are innervated by the facial nerve. Also realize most of the saliva is secreted by the submandibular gland, despite the larger size of the parotid gland. Cranial nerve 10 is the vagus nerve. While we're very aware of its visceral responsibilities in the thorax and the gut, it has a couple other responsibilities. One is it has a little bit of general sensory to the skin and around the ear and within the external auditory tube. It also provides special sensation or taste from the epiglottis and sometimes in parts of the very, very back of the tongue or in the pharynx. It also provides very important motor information to the muscles of the pharynx and the larynx, as well as some of the muscles of the soft palate and the tongue. Cranial nerve 11, the spinal accessory nerve, is familiar to us at this point. It's quite a unique nerve because it originates from the cervical spine. It ascends up the spinal cord through the foramen magnum, shown here by this ring, and then ultimately exits out through the jugular foramen with cranial nerves 9 and 10. Thus, it's considered a cranial nerve by many anatomists. Recall that the spinal accessory nerve descends down the neck, innervates the sternocleidomastoid, and then continues obliquely to innervate the trapezius muscle. Last but not least is cranial nerve 12, the hypoglossal nerve. Very important nerve because this nerve allows us to talk. It is responsible for innervating the tongue. So it's a motor-only nerve. There is no sensory contribution from the hypoglossal nerve. So it's responsible for going in and innervating all the intrinsic muscles of the tongue. It gets out of the cranial vault via its own canal called the hypoglossal canal just above the foramen magnum. Here on the bottom part of the slide, we can see a summary of the parasympathetic ganglia and the nerves that serve the head and the neck. Recall that we have cranial nerve 3 contributing to pupillary constriction and lens accommodation. It acts through the ciliary ganglia in the orbit. Cranial nerve 7 provides lacrimal gland secretion through a ganglion called the pterygopalatine ganglion. Cranial nerve 7 also acts on the submandibular and sublingual gland for salivary secretion through the submandibular ganglion. Cranial nerve 9 acts on the parotid gland for its salivary secretions through the otic ganglion. And cranial nerve 10, as you recall, have many actions parasympathetically, acts at synapses very close to the target organ. Cranial nerves play a key role in assessing a patient, particularly one that may have neurologic involvement. Cranial nerve reflexes are a useful tool for clinicians when assessing the patient. The most important is the pupillary light reflex. Reflexes have an afferent limb or an afferent path and an efferent limb or efferent path. So you have incoming information from the outside stimulus going through the afferent path, and then you have a motor response through the efferent path. For instance, let's take a look at the pupillary light reflex. Here you are, the clinician, shining a light in your patient's left eye. The retina picks up the image, and that image is brought back by the afferent limb of the light reflex, cranial nerve 2. So this is the left optic nerve that brings light via both directions into the upper brainstem. The signal is processed, and through a series of other structures, there is an outgoing information via the right cranial nerve 3, that's what this black line indicates, and the left cranial nerve 3. So that's a consensual reflex. We're going to have a response in both eyes. What kind of response? Well, if someone shines a bright light in your eye, you're going to want some pupillary constriction on both sides to let less light in. So that's the pupillary response. if you try to do a jaw jerk reflex, the stretch receptors in the muscles of mastication will send an afferent signal back through the semilunar ganglion and into the brainstem, and then there will be a motor response out via cranial nerve 5. So cranial nerve 5 has the afferent path and the efferent path. The blink reflex, because cranial nerve 5 is responsible for sensation in the head, cranial nerve 5 will carry a sensory signal from the cornea, and then an efferent signal from cranial nerve 7 will be produced so that the orbicularis oculi will contract so you can have a blink. The gag reflex is stimulated by cranial nerve 9, by the glossopharyngeal nerve, so the sensation by cranial nerve 9 on the back of the pharynx. And then there'll be a motor response by all those muscles via the fourth branchial arch by cranial nerve 10. That concludes this discussion on the cranial nerves. This is a humorous image, although rather incomplete, showing cranial nerve 9 for the posterior 1/3 of the tongue. While that's correct, we have a 12 here on the tip of the tongue, presumably insinuating the motor for the intrinsic muscles of the tongue. However, there's an absent 7, which should be here. Let's draw that in. That's going to be 7 is carrying taste fibers. And then we would also have in the same area, I'll just draw it next to it, 5. That's the sensation for the anterior 2/3 of the tongue. I hope this was helpful in sorting out the cranial nerves. Please let me know if you have any comments or questions.